Welcome back to the deep dive. Today, we're tackling a really complex area in medicine.
Yeah, it's this intersection. What happens when the drugs meant to help, specifically psychiatric meds, actually cause, serious movement problems?
Right, we're talking common stuff too, like SSRIs, lithium, antipsychotics, even anticonvulsants sometimes.
Exactly. And these aren't just minor side effects. They can range from, well, genuine emergencies,
Yes,
life-threatening situations.
down to chronic things that are just deeply upsetting for patients.
Right. So our goal here, our mission for this deep dive, is to give you a really clear, quick way to understand these conditions
How to diagnose them fast, categorize them.
and know the absolute key steps for management, whether the patient is, crashing or seems relatively stable.
Okay, let's start with that unstable picture then, because the urgency there, it's paramount. Before we even worry about what syndrome it is, what's the absolute first thing?
The absolute first step, forget the specific diagnosis for a second, is confirming stability. You run the ABCDE assessment?
Airway, breathing, circulation. The basics.
Absolutely.
Yeah.
If they're unstable, that's a priority. Maybe they need oxygen, maybe intubation, IV fluids, continuous monitoring. You stabilize first.
But, I mean, doesn't that delay figuring out if it's something specific, like serotonin syndrome or NMS? How quickly do we need to move to that diagnosis?
And we can't wait long, obviously. But it's sequential, you see. Stabilize the immediate threat, then work on differentiating the big crises
Okay.
and thinking about the underlying mechanism that really helps tell them apart. It's a really high-yield way to think about it.
Got it. So let's start with serotonin syndrome. SS cause is pretty clear, right? Too much serotonin, overdrive.
Exactly right. Think hot and wet. It's a hyperserotonergic state, usually from serotonergic meds like SSRIs, TCAs.
The usual suspects.
Right. But here's a key thing, a potential blind spot. You really need to ask about non-psychiatric drugs, too.
Ah, okay. So if someone comes in looking like this, you're grilling them about everything they take.
You have to. Our sources flag 3 non-psych meds specifically. The opioid tramadol, the muscle relaxer, cyclobenzaprine, and even an antibiotic, linezolid. They all have serotonergic effects.
Wow, okay. That's a huge clinical pearl for taking that history.
It really is.
So what does this serotonin overdrive look like clinically?
Well, hot and wet, so high temperature, high blood pressure, fast heart rate. And the key movement findings are hyperactive.
Hyperactive, meaning?
Hyperreflexia, those
Yeah.
really brisk reflexes, plus tremor, or sometimes myoclonus, those sudden muscle jerks, and they're usually sweating profusely diaphoresis.
Okay. And the number one management step?
Stop the offending agent.
Yeah.
Immediately stop all serotonergic medications. That's the single most critical thing.
Then supportive care.
Supportive care, yes.
Yeah.
And maybe anticonvulsants if seizures are part of the picture.
Okay. Now the other big emergency, neuroleptic malignant syndrome. NMS rarer, but potentially lethal. And this one's linked to dopamine blockers.
Exactly. Especially first-generation antipsychotics. If SS is hot and wet, think of NMS as hot and stiff.
Stiff. Okay.
The mechanism here is profound dopamine blockade in the brain. It usually shows up within, say, the first month of starting the drug, or maybe after a dose increase.
And the symptoms reflect that dopamine block, I assume?
They do. Unlike the sort of hyperactive picture in SS, NMS is defined by intense, generalized muscle rigidity, sometimes called lead pipe rigidity.
Lead pipe. Wow.
Yeah. They also have very high fevers, also sweating, and altered mental status. Vitals can be all over the place, high or low BP, but usually tachycardia.
Is there a lab test that really points towards NMS?
Yes, absolutely. Creatine phosphokinase, CPK. That's the really high-yield lab here.
Why CPK?
Because of that intense rigidity, you get massive muscle breakdown, rhabdomyolysis. So the CPK is usually sky high, like more than 10 times the upper limit of normal.
Okay.
You might also see a high white blood cell count, raised liver enzymes, signs of kidney strain too.
So given the different cause dopamine blockade, does the management differ beyond just stopping the drug and supportive care?
It does. Because it's a dopamine blockade problem, we sometimes try to counteract it with a dopamine agonist, like bromocriptine.
Trying to kickstart the system again?
Sort of, yeah.
Right.
And for that severe rigidity, we might use a potent muscle relaxant like dantrolene. And interestingly,
Yes.
for really severe refractory cases, electroconvulsive therapy, ECT, can actually be life-saving. It can break that cycle of rigidity.
Fascinating. Okay, that gives us a really clear framework for the unstable patient, SS versus NMS, hot and wet versus hot and stiff.
Exactly.
So let's say we've averted that crisis or the patient presents differently. They're stable, maybe they just started a new psych med or up the dose, and now they have some weird movements, maybe a tremor or they feel restless. Where do we go from there?
Okay, so if they're stable, the job becomes classifying the type of movement. The physical exam is key here.
Yeah.
Are we seeing sustained contractions? That points to dystonia.
Yeah.
Or is it more of an oscillating movement? That's tremor.
Huh.
Or is it this inner feeling of restlessness? That could be akathisia. Let's start with dystonia.
Acute dystonia, that sudden, scary muscle lockup. Much higher risk with the older antipsychotics, right? Like 10% versus maybe 2% with the newer ones.
That's right. And the ways it shows up can be really dramatic, visually striking.
Like what? Give us some examples.
Think torticollis, the sternocleidomastoid muscle just clamps down, pulls the head and neck way over. Painful.
Yeah.
Or trismus, the jaw clenches tight. Or the oculogeric crisis, the eyes get stuck looking straight up.
That sounds terrifying for the patient.
It absolutely is. Or even aposotnos, where the whole back and neck arch backward.
You mentioned it's usually not life-threatening, but there's one big exception.
Exactly. The one time it can be an emergency is if it involves the throat muscles, the glossopharyngeal muscles.
Yeah.
That can actually block the airway.
Ah, okay. So even a stable dystonia patient needs that airway check.
Always keep it in mind.
How do we tell acute dystonia apart from something like catatonia? Both can involve weird postures.
Yeah, good question. High-yield distinction. Acute dystonia is an active, painful contraction. The patient is usually distressed, fighting against it. You try to move their neck back, you can't.
Right.
Catatonia is different. It often has this waxy flexibility. You can sort of passively move their limb into an odd position, and they just hold it there. They're often withdrawn, maybe mute. Different feel entirely.
And treatment for acute dystonia if it's not choking them?
Usually quite effective and fast. An intramuscular shot of an anticholinergic like diphenhydramine Benadryl or benzodiazepine often resolves it quickly.
Okay, so that's sustained contraction. What about the oscillating movements? Tremors, you said there are different kinds.
Yes, crucial difference here between postural tremor and resting tremor, which is part of Parkinsonism or EPS.
Okay, postural tremor first. How does that look?
You see it when the patient tries to hold a posture against gravity, like holding their arms stretched out. It's usually a fine tremor, mostly in the hands.
And what causes that?
Common culprits are things like lithium, some antidepressants, stimulants, even too much caffeine. Importantly, with a pure postural tremor, you don't see the other signs of Parkinson's, like stiffness or slowness.
Ah, okay. But if you do see that stiffness and slowness,
Then you're likely dealing with drug-induced Parkinsonism or extrapyramidal symptoms EPS. The tremor here is typically a resting tremor.
meaning it's worst when?
Worst when the limb is completely relaxed, like resting in their lap. Then you also find that cogwheel rigidity, that ratchet-like feeling when you move their limb.
Mm-hmm.
Bradykinesia, which is just slowness of movement, and often that shuffling gait. It looks a lot like Parkinson's disease.
And the cause is that dopamine blockade again, like NMS, but less severe.
Exactly. Same mechanism, different intensity. Often related to the dose of the antipsychotic, but other drugs can cause it too.
So management for EPS probably relates back to dopamine too.
It does. Best option, if possible, is to stop or reduce the dose of the offending drug. Symptoms often resolve then.
And if you can't stop the drug,
Then we use medications to try and rebalance things. Anticholinergics again, like benzodiazepine or diphenhydramine, or sometimes amantadine, or even benzodiazepines.
okay. So we've covered sustained contractions, dystonia, and oscillating movements, tremor, EPS. What if the patient is stable, but it's neither of those?
Then you have to consider akathisia. This one's tricky,
Body tricky.
because the main symptom isn't the movement itself. It's this horrible internal feeling of restlessness. Patients describe it as torture, like they need to jump out of their skin.
Wow. So it's a subjective feeling driving the movement.
Precisely. The pacing, the fidgeting, the marching in place, constantly shifting position. That's all driven by this unbearable inner sensation.
I can see how that could be missed or misdiagnosed as just anxiety or agitation.
Exactly. And then, tragically, someone might increase the dose of the antipsychotic or antidepressant causing it, thinking they're treating worsening anxiety.
Oh, wow.
Yeah. They might be able to suppress the movement for a few seconds if you ask them to, but that internal drive is overwhelming.
What drugs usually cause akathisia?
Antipsychotics are common culprits, also antidepressants, less often, things like antiemetics.
And how do you manage that inner torment?
Lowering the dose of the suspected drug is key. or switching to a different medication class if possible. Adding a low-dose benzodiazepine can sometimes provide significant relief from that awful internal feeling.
Okay, one more major category to cover. Tardive dyskinesia, TD. This is the one people really worry about long term, isn't it?
It is. TD is about chronicity. You're looking for involuntary movements that have been going on for at least 4 weeks.
And it's typically seen in people on antipsychotics for a while.
Usually, yes. Typically over 3 months, although it can sometimes emerge within weeks of stopping a long-term antipsychotic. It's mostly associated with the older first-generation drugs, but newer ones aren't entirely risk-free, except for one,
Which one is that? High yield fact time.
clozapine. It's generally considered the only antipsychotic with minimal risk of causing TD.
Okay. And what do these TD movements actually look like? Paint us a picture.
The classic image involves the mouth and face. Think repetitive, involuntary movements like lip smacking, puckering, chewing motions.
Like they're chewing invisible gum.
Exactly.
Yeah.
Or grimacing, tongue darting in and out. But it can also involve the limbs or trunk, with movements that are coriform, kind of rapid, jerky, dance-like, or aethetoid, more slow, writhing, sinuous.
It sounds potentially quite disfiguring and distressing.
It absolutely can be. And the prognosis,
Yeah.
well, it's guarded.
Meaning?
In milder cases, especially in younger patients, the movements might improve or remit if you stop the offending drug.
Yeah.
But, and this is critical,
Yeah.
if the patient is elderly or the TD symptoms are already severe, they're unfortunately unlikely to resolve even after stopping the medication.
I mean,
Changes can be permanent.
Permanent. Wow. That's sobering. So if it's established and maybe permanent, what can we actually do for these patients?
Thankfully, we do now have 2 FDA-approved treatments specifically for TD, valbenazine and deuterbenzine. They work on modulating dopamine release.
So there are options, even if stopping the original drug isn't enough?
Yes, these treatments are really important tools now.
Okay, this has been incredibly helpful. We've really broken down these complex disorders, distinguishing the emergencies, SS, hot and wet, hyperreflexia,
Versus NMS, hot and stiff, with that massive CPK rise.
and then for the stable patient, working through dystonia, sustained contraction, tremor, postural versus resting EPS, and akathisia, that inner restlessness.
Understanding that framework lets you move fast. You see abnormal movements, and you can quickly triage. Is this an emergency needing immediate stabilization? Or is it something like dystonia needing an anticholinergic, or EPS, or TD needing specific treatment?
It really empowers you to have those crucial conversations about risks and benefits when starting these medications.
Absolutely. Which leads us to a final thought.
Go on.
We just highlighted that severe tardive dyskinesia, particularly in older folks, often doesn't go away. It can be a permanent consequence of necessary treatment. So that raises a really tough ethical and practical question, doesn't it? How do we, as clinicians, patients, families, how do we best weigh the immediate need for psychiatric stability against the potential for causing a permanent life-altering movement disorder down the road?
A profound challenge with no easy answers. Definitely something for all of us to think more about.